Hello and welcome. This is Dr. Alexandra Kopelovich, and today we will be taking a look at skeletal muscle mechanics. Skeletal muscle mechanics is the study of how the internal characteristics of muscles, along with external factors encountered by muscles, affect overall muscle strength and function. Some internal characteristics are contractile and non-contractile proteins, length tension curves, motor unit recruitment, fiber composition, muscle shape, physiological cross-sectional area, and external factors are external load, location of external load, presence of pulleys in the environment, position of a segment of the body in regards to gravity. In this webinar, we will examine the role of muscles and tendon in generating, modulating, and transmitting force. These functions are necessary to stabilize and move skeletal structures. The function of muscles explored with regard to how it produces passive tension from being elongated, or how it generates active force as it's activated by the central nervous system. So let's review muscle composition. A whole muscle is composed of many individual muscle fibers. They typically range from 10 to 100 micrometers in thickness and from 1 to 50 centimeters in length. Sarcomere is a fundamental unit within each muscle fiber. Each muscle fiber is an individual cell with multiple nuclei. Contraction of individual muscle fibers is responsible for contraction of a whole muscle. So we have some contractile proteins, non-contractile proteins, and extracellular connective tissue. Contractile proteins are actin and myosin. Non-contractile proteins, their action is to generate passive tension when stretched, provide internal and external support and alignment, and help transfer active forces. And some of the extracellular connective tissue are epimysium, perimysium, and endomysium. Extracellular connective tissue, along with structural proteins, are classified as non-contractile tissue. Let's take a look at muscle morphology, or the shape of the muscle. The two most common shapes are fusiform and pennate muscles. Fusiform is demonstrated right here. Typically, you would think of a bicep when the fibers run parallel to the tendon, and pennate muscles when the fibers approach their central tendon obliquely. So we have a couple examples here. We have unipennate, bipennate, and multipennate muscles. And some examples that we can think of is the quadricep muscle group or the gastrocnemius. Physiological cross-sectional area. It reflects the amount of active proteins available to generate force. Maximal force potential is proportional to the sum of cross-sectional area of all of its fibers, which means the thicker the muscle, the more force it will be able to produce. Let's take a look at pennation angle. If a muscle attached parallel to the tendon, the pennation angle would be 0. So angle of pennation is angle of orientation between the muscle fiber and the tendon. So an example of 0 degrees of angle of pennation is right here, a hamstring muscle. The fibers are oriented at 0 degrees to the tendon. Oblique orientation of muscle fibers. It's beneficial because we're able to fit more muscle fibers into a given muscle, such as demonstrated right here in the quadricep group. It will produce greater maximal force than fusiform muscles, demonstrated right here. So, once again, if a muscle attached parallel to the tendon, the pennation angle will be 0. In this case, all of the force generated by the hamstring muscle is transmitted to the tendon and across the joint. So if muscle generates 100% of force, 100% of that force will be transferred onto the tendon. If the pennation angle is greater than 0, as demonstrated right here, then only part of its force is transmitted through the tendon. In this example, the pennation angle would be around 30 degrees, transmitting only 86% of its force through the tendon. So it doesn't seem beneficial to our system. So once again, why is pennation angle? Why is pennate muscles are able to produce more force? We're coming back to this concept. Pennate muscles are able to fit more fibers into a given area of the muscle. Therefore, we increase the physiological cross-sectional area and able to produce more force. A large pennation angle reduces the transfer of force from muscle fiber to the tendon. But this reduction is small in comparison to large force potential gained in physiological cross-sectional area. Let's take a look at passive length tension curve. For functional purposes, we can describe non-contractile tissues as parallel and series elastic components of a muscle. Series elastic components are tissues that attach in series with active proteins. So these are the active proteins, actin and myosin. And tendon and large structural proteins are in series with actin and myosin. Parallel elastic components are tissues that lie parallel with active proteins. So you can see that extracellular connective tissue lays parallel to actin and myosin. Stretching a whole muscle by extending a joint elongates both the parallel and the series elastic components. Passive length tension curve. Elongate a muscle to the end range. So if you elongate your wrist to the end range, both contractile and non-contractile components will elongate. This will result in a spring-like feeling of resistance, which created by the passive tension. So let's take a look at this passive length tension curve. On the x-axis, we're increasing the muscle length, meaning we're elongating the muscle, increasing the stretch. On the y-axis, we're producing tension or force. So, when you just start elongating your wrist, you start from slack when the wrist is completely flexed. Then you start slightly going into a neutral wrist position from flex position. Passive elements start generating tension here. At some point, we reach a critical length when all of the relaxed tissues are brought to initial level of tension. So it's about a slightly past neutral position in your wrist. And finally, as you keep going into an extended position of the wrist, tension is progressively increasing until higher tension. At some point, when you reach the highest tension, the tissue will rupture or fail. So this was passive length tension curve. The physiological benefits of passive length tension curve is passive tension protects the muscle from injury when going into maximum elongation. It enhances joint stability and improves efficiency of the ideal gait. So let's take a look by what mechanism it improves efficiency of the ideal gait. It improves the pre-stretch of the gastrocnemius and Achilles. Passive tension within stretched muscle serves many useful purposes, such as moving or stabilizing a joint against the forces of gravity, physical contact, or other activated muscles. Take a look at this example of passive elongation of the gastrocnemius and Achilles tendon at the end of the stance phase of walking, just before the push-off. So this would be if you follow the demo's right leg, this would be right just before that. right here, just before the heel leaves the ground. Passive tension here assists with transmission of muscular force through the foot and to the ground, thereby helping to initiate the propulsion phase of walking. Now, let's take a look at active length tension curve. The regular organization of the filaments produces a characteristic banded appearance of the myofibril as seen under the microscope right here. So myofibril contains, as we mentioned, active proteins, myofilaments. We have actin and myosin. We have a sarcomere, which is a fundamental active force generation of the muscle. We have a number of different bands. A band, for instance, is only myosin fibers, and that's the dark one. I band is the light band and contains only actin proteins, and H band is the band where there is no overlap of actin and myosin together. So, sliding filament theory. It's a model for describing active force generation within a sarcomere. Active force is generated as actin filaments slide past myosin filaments, producing Z discs and narrowing the H bands. Progressive overlap of actin and myosin creates shortening of each sarcomere. Cross bridge formed by myosin head attaching to actin, as demonstrated right here. So the pink is the myosin, the light pink is actin. As the cross bridge is being formed as myosin heads attach to the actin and create a power stroke. Cross bridges are formed by coupling of actin and myosin myofilaments. Once a cross bridge has been formed between the two myofilaments, contraction occurs, resulting in filaments sliding past one another. The cross bridge is broken in one of the two events. One, if the muscle is relaxing, so the muscle is returning to its original length. Or in the second event is when another action potential is stimulated, therefore another contraction has to be formed, another cross bridge. Amount of force generated depends on the number of simultaneously produced cross bridges. The greater the number of cross bridges, the greater the force generated within the sarcomere. A consequence of arrangement between actin and myosin, the amount of force depends on the instantaneous length of the muscle fiber. A change in fiber length from active contraction or passive elongation alters the amount of overlap between actin and myosin, and therefore the number of cross bridges available to form. So let's take a look at the active length tension curve. Figure here demonstrates an active length tension curve of a sarcomere for 4 specified sarcomere length. So with x-axis, we're looking at the length of the sarcomere as it gets longer, so the muscle is progressively gets longer. And at the y-axis, we're looking at the active tension or the force produced by the muscle. Actively contract or position a muscle to the end range. So once again, you actively contract your wrist flexors. So we're going to start right here. So wrist flexors are contracted when the fingers are flexed and wrist is flexed. Both contractile and non-contractile components will shorten. So right now we have complete wrist flexion and finger flexion. Now, in position A, actin filaments overlap so that the number of cross bridges is reduced. So you're looking at the overlap right here. So if you're trying to produce tension when your wrist is completely flexed and your fingers are completely flexed, you're going to be at position A. And here we're unable to produce maximum amount of tension because we're in a completely shortened position A. There's already so many cross bridges that can be formed. Now, as we slowly stretch our wrist out to a neutral position but continue gripping, squeezing the fingers, we're reaching position B and C. Actin and myosin are positioned to allow an optimal number of cross bridges, B and C. And you can see how here we can form an optimal amount of cross bridges. And finally, as you keep elongating your wrist to wrist extension and continue to squeeze your fingers together, you're unable to produce maximal tension once again because you're in position D right now. Active filaments are positioned out of range of myosin heads so that no cross bridges can be formed. You can see how the actin is very far from myosin. In A and D, we notice the reduction in number of available cross bridges, both A and D. So that reduces force generating potential of the muscle. So let's take a look at the concept of resting length. It's a maximum number of actin and myosin cross bridges available for formation. So the more cross bridges we have, the more force we will be able to produce. So the ideal length would be the position B and C for force production. Here we have the number of possible cross bridges. Once the muscle starts shortening or lengthening, the number of possible cross bridges declines, right? So in position A, we're unable to produce maximum amount of cross bridging, and same thing in position D. Actin and myosin are further away from each other, making it harder to form the cross bridge. That's description of position D. The force generating potential of the muscle will be impaired, as mentioned before. Now, the combination of active tension and passive tension allows for a large range of muscular force over a wide range of muscular length. So that's exactly what we get when we add up passive tension and active tension together, the total length tension curve. So once again, at the x-axis, we're looking at increasing the length of the muscle, and y-axis, we're looking at increasing tension or production of force of the muscle. Passive tension contributing to the curve allows muscle to maintain high levels of force, even as the muscle is stretched to a point at which its active force generation is compromised. High levels of passive tension is more apparent in muscles crossing multiple joints. So once again, coming back to this curve. In position A right here, the force is generated by the muscle actively. As we progress to position B, passive tension begins to contribute to the force produced by the muscle. So now we don't see that decline anymore if it was only active force produced. We also have this passive length tension curve, which contributes to the total force production of the muscle. And finally, position C. The muscle is further stretched, and passive tension accounts for most of the total force, as we can see right here. Okay? So once again, the combination of passive tension and active tension allows us to generate more force, a larger amount of force. Optimal length tension of a muscle is a zone in which there are an optimal amount of actin and myosin cross bridges available for formation. Optimal cross bridges available equals to the optimal force production. So how can we take advantage of the optimal length of a muscle while in the clinic? It seems to be very narrow window of opportunity. So the answer to this is in the ability to slightly pre-stretch a muscle before you contract the muscle. Observe how the optimal length of a muscle is where the most force is produced from the muscle. Realize that the optimal length is actually on the passive length tension side of the curve, and the muscle is being stretched not contracting. So let's take a look at this example. A patient is having difficulty with sit to stand movements from chair or bed. As long as the patient doesn't have a total hip replacement, you will hear your CI tell the patient to get their nose over their toes. So why is the CI giving patient these commands? One reason, the patient will rock back and forth a few times to generate some momentum and blast up off the chair. So the first reason is to create momentum. The second reason is to actually pre-stretch gluteus maximus, producing a slight bump in force-producing capabilities of gluteus maximus. So as we get the nose over the toes, we slightly pre-stretch gluteus maximus, coming back to this curve. So we start from this end of the curve because we're going to go into decreasing muscular length. So we pre-stretch it to create some forcivity. And then we're going to go into muscular contraction of gluteus maximus, of course, to continue generating that force to allow the patient to get up from sit to stand. Now, we will take a look at concepts of insufficiency, active and passive insufficiency. Multi-joint muscles are muscles that cross more than one joint. A general consensus is that all muscles can only shorten to about 70% of their resting length. Resting length is, let's say for a given muscle, it's 100 centimeters. So muscle can only shorten to 70 centimeters. The answer is not 30. In order for it to be 30, the sentence would read, muscle can shorten to about 30% of their resting length. If a muscle contracts over two joints, the 70% barrier will be reached very quickly. Significantly diminished force production from a muscle as it has actively and fully shortened across two or more joints is demonstrated right here by active insufficiency. Active insufficiency occurs when a two-joint muscle has shortened so much that it can no longer develop functional strength or force in order to move a joint through its full available range of motion or hold a position against an external force. So in this example, we're creating an isometric resistance of finger flexors. So the finger flexors are trying to hold the dumbbell in one place. This is a position of active insufficiency of finger flexors. The muscles will be weak and have a hard time moving a joint or holding a joint position, especially if resistance applied, so right here as holding a dumbbell. So a better position for this muscle would be not flexing over the two joints, right? So finger flexors are here in the shortened position. And we're going to go back to this slide right here of active insufficiency curve. So we are in position A of active insufficiency. So here we have a maximum overlap of actin and myosin fibers, and that creates active insufficiency of the muscle. So what we want to do is slightly elongate the wrist joint in order to come back to positions B and C. So again, where's the curve? To positions B and C to be able to produce an optimal amount of force. So this position B and C is demonstrated here. So slight wrist extension with finger flexion will allow more power generation through wrist flexors. Active insufficiency is named by the muscle that has actively shortened fully, thereby interfering with the force generating potential and possibly preventing a joint from reaching its full available range of motion. So the correct answer here is active insufficiency of wrist flexors. Now, let's take a look at passive insufficiency. It's the inability of a joint to move through its entire available range because of passive tension generated by a fully lengthened multi-joint muscle. The muscle will be so tight and generate so much passive tension that it will prevent you from achieving full available range of motion. So let's take a look at an example here. So in the first image, labeled A, notice a large range of metacarpophalangeal, proximal interphalangeal, and distal interphalangeal joint extension. So when the wrist is completely flexed, our fingers are completely extended, or let's say in a neutral flex position. Notice the loss of finger extension across the MCP, PAP, and DAP joints as we go into wrist extension. So when the patient moves their wrist into wrist extension, and you can try it in your own wrist and you will notice the same thing, you will notice right away that without control, without active control, your fingers passively go into flexion. So MCP, PAP, and DAP joints all move into flexion. Finger flexors, FDS and FDP, flexor digitorum superficialis and flexor digitorum profundus, are maximally elongated right here at the wrist, at MCP, and all of these joints right here. So the opposite muscle, extensor digitorum, can now no longer fully extend the fingers because FDS and FDP are maximally elongated at the wrist. Passive insufficiency is named by the muscle that are producing passive tension, limiting the range of motion. So the correct name would be passive insufficiency of finger flexors. We're passively elongating finger flexors, which doesn't allow us full wrist extension. So an incorrect terminology would be passive insufficiency of finger extensors, because we're not stretching the finger extensors in this example, or active insufficiency of finger extensors. Once again, we're not actively the finger extensors are not actively insufficient. We're creating this position because there is passively finger flexors are unable to elongate to allow wrist extensors to create full range of motion. So here's side-by-side comparison of active and passive insufficiency. Active insufficiency significantly diminishes force production from a muscle as it has actively and fully shortened across two or more joints. This could affect the muscle's ability to move a joint into full available range of motion. Passive insufficiency is the passive tension developed within a muscle when it's fully elongated. It prevents a joint from reaching its full available range of motion. Thank you for your attention.